Hello and welcome to the Primary Peritoneal Cancer 101 recording. I'm Maggie Nicholas Alexander, the Senior Director of Gynecologic Cancer, Patient Support and Education at SHARE. For more information about upcoming webinars, support groups, our helplines, and more, please visit our website at sharecancersupport.org. Today we're speaking with Dr. Dellinger. Before we begin, I'd like to hand it over to Dr. Dellinger to introduce herself.
Okay. Hi, this is Thanh Dellinger. I'm a GYN oncologist and associate professor at the Division of GYN Oncology at City of Hope in Duarte in California. I've been doing this for the past 12 years, and my expertise specifically is in peritoneal cancers, and I am an expert in HIPEC and PIPEC and other novel intraperitoneal therapies.
Great. We're so happy to have you here today.
Great. Yes, I'm happy to be here as well. So I hope that you can all see my screen. So I will be talking today about primary peritoneal cancer. So let me see here. Okay, good. So we'll be talking about the differences between primary peritoneal cancer and ovarian cancer. The risk factors and causes of this cancer, how they present, what the treatment is, and what is the latest in the research for primary peritoneal cancer. So let's first start defining what is the peritoneum. It is not a well-known organ to most people and even physicians. So the peritoneum is a layer that covers all of the organs within the abdomen, your tummy, as well as almost like an inner skin that covers the inner lining of the abdomen and the organs such as the bowel, the intestines, the liver, and other organs. So the parietal peritoneum is the lining, the peritoneum that covers the inside of the abdomen, kind of like an inner skin. And then the visceral peritoneum is the layer that covers the organs, including the uterus, the liver, the intestines. There's a little bit of fluid that usually is in between these layers, which in the intraperitoneal cavity, and that is normal. That's just helping with kind of the separation of these layers. Now, primary peritoneal cancer is a pretty rare cancer. And we think that the primary peritoneal cancer arises from the inner lining, the peritoneum of the abdomen. But there's other peritoneal cancers as well, which are not primary. They arise from GI cancers, colorectal, gastrics, and those are essentially non-primary peritoneal cancers. But primary peritoneal cancer is really a rare cancer that arises from the peritoneum, not the ovary, but behaves very similar to the ovarian cancers. And we think that that is because in embryogenesis, so when an embryo forms and the organs form within an embryo, that the primordial cells that become the ovary and the peritoneum, they derive from the same primordial cells. So we think that therefore the two cell forms have similarities, and therefore primary peritoneal cancer behaves very similar to ovarian cancer and tubal cancer. But really, the two cancers, primary peritoneal cancer and ovarian cancer, are treated in the same way. They present maybe in slightly different ways, though pretty similarly, but the treatment and the prognosis is the same. So when your doctor might be talking to you about ovarian cancer, but you have primary peritoneal cancer, the two really are interchangeable when it comes to treatment. So primary peritoneal cancer is a rare cancer that affects women. In the US, it only affects about 10% of all women who have ovarian or fallopian tubal cancers. We don't really know the causes of primary peritoneal cancer. It's likely multifactorial, meaning that it's caused by many different reasons. Most primary peritoneal cancer patients do not have the BRCA1 or 2 gene, which affects about 15 to 20% of all ovarian cancer. It's an inherited gene that gives you an increased risk for breast and ovarian cancer. Another difference between ovarian and primary peritoneal cancer is that primary peritoneal cancer does not present in stage 1 or stage 2. It only presents as a stage 3 or stage 4. And in stage 3, for example, it mostly affects the omentum, which is the fat apron that hangs from the colon in the stomach and protects the abdomen. But that is a main area location for primary peritoneal cancer to occur. But the cell type that affects ovarian cancer is the same as what we see for primary peritoneal cancer. And the most common one is high-grade serous. Serous is the cell type that we frequently see in this cancer. So how do primary peritoneal cancers present? Well, they really present the same way as ovarian cancers. And unfortunately, these are very vague symptoms. They tend to be very vague abdominal and GI symptoms. And the most common symptoms we see are abdominal bloating, abdominal fullness, abdominal pain, or potentially the desire or the need to go to the bathroom more frequently, to pee more frequently. But it's very vague symptoms, often misdiagnosed by primary care physicians. And because it's really a symptom that could occur in many other GI disorder. And so it's difficult to diagnose it. So what are the tests to diagnose? Well, the first thing oftentimes that a patient will obtain is go to the primary care physician and have an abdominal and pelvic exam. And the abdominal exam will really mean pushing on your abdomen, seeing whether you have ascites, which is fluid that fills the abdomen, and doing a pelvic exam. So essentially a vaginal exam to see whether there's any palpate for any pelvic masses, ovarian masses. And then a blood test. So the tumor marker that we use in ovarian cancer is called CA-125. This is a blood test that is used for ovarian cancer and is also used for primary peritoneal cancer and is usually elevated when you have primary peritoneal cancer. But CA-125 level is not an incredibly diagnostic marker. We use it to monitor ovarian cancer and primary peritoneal cancer, but unfortunately, the test is more of a marker of inflammation, and so therefore it can be elevated in other types of non-cancer conditions, such as endometriosis or fibroids, which are all benign conditions that can cause irregular menses and pelvic pain. Pregnancy can cause an elevated CA-125 level, pelvic inflammatory disease. So there's a number of different benign conditions that can cause a mild or even moderate elevation CA-125. So we frequently rely on imaging studies to diagnose ovarian and primary peritoneal cancer. The most common tests used are a pelvic ultrasound. So this is an ultrasound that uses sound waves to build a picture. Frequently, it's an endovaginal, so intravaginal, as well as an abdominal ultrasound to look for ovarian masses. And then the most common and really the more definitive test is a CT scan. That includes from the neck down to the pelvis, so chest, abdomen, pelvis, or alternatively an MRI of the abdomen, pelvis to take a look whether there is masses, pelvic masses, ovarian masses in the abdomen, whether there's any other spread of cancer, whether there's any fluid such as ascites or pleural effusion. So the stages for primary peritoneal cancer, as I mentioned, are similar to ovarian cancer, except there's no early stage. There's no stage 1 or stage 2. All primary peritoneal cancer automatically either stage 3 or stage 4. So the most common area of presentation is usually in the omentum. Omentum is the fat apron that I mentioned earlier, or somewhere in the peritoneal area, whether it's on top of the colon, the intestine, whether it's in the pelvis, in the peritoneal layer. That's usually where we see primary peritoneal cancer. And so when it's within the abdomen, it's considered stage 3. Once it has spread beyond the abdomen, such as, for example, into the lungs and the chest with fluid, or into lymph nodes in the neck, then it's considered a stage 4 primary peritoneal cancer. So the treatment for primary peritoneal cancer is really the same as for ovarian cancer. And it depends on a number of different conditions, but the combination is usually surgery and chemotherapy. And in what order that is done depends on whether the cancer is spread outside the abdomen. So for example, whether you have any lesions in the lungs, fluid in the lung, or lesions in the lymph nodes in the neck, or whether every tumor is still contained within the abdomen, within the belly. And also your general health is being considered, and whether you can tolerate a surgery up front. So usually the best method is to do a surgery first to remove all of the cancer, every single millimeter of tumor inside the abdomen, and then follow up with chemotherapy. Now, if that is not possible, either cancer spread outside of the abdomen or your general health isn't good enough to tolerate a big surgery, then we give chemotherapy first. We call that neoadjuvant chemo, and then follow it up with surgery and more chemo. But the goal of the treatment for advanced ovarian and primary peritoneal cancer is really to shrink the cancer and control the tumor for as long as possible. So we talked a little bit about surgery already. Surgery in ovarian and primary peritoneal cancer is typically referred to as the debulking surgery, which to many women and patients really sounds like a really ominous term. And in some ways it is. It is a very big surgery for many women, not all. But at a minimum, it involves a hysterectomy and removal of the ovaries, unless one or the other have been removed in the past. And for most women, it is a big surgery. It is an up and down incision throughout the entire abdomen in order to expose every single corner of the abdomen. So we want to look behind the liver. We want to look all around the stomach, in the pelvis, on all of the intestines. So we really need a big area, a big incision to look at everything. And then we get to work and we remove every single millimeter of tumor when feasible. And that might involve removing what is seen here, the diaphragm. The diaphragm peritoneum is the layer that is between the chest and the abdomen. And oftentimes tumor can occur in that area. It sometimes involves the colon or the small bowel. And this picture specifically shows that the colon, this is the rectum actually, which sits right behind the uterus and the ovaries, can oftentimes have tumor nodules and then requires cutting out that portion of the colon, just like as you see here, and then putting those portions together. So this portion with the portion below this area where the tumor is. Sometimes the small bowel is involved, and then the same cutting out of the tumor and reconnecting it occurs. So as you can see, this can be a quite extensive surgery. It's a long surgery, and it really has one singular goal, which is to remove every single millimeter of disease that we can see, and safely do. Now, every primary peritoneal cancer patient will require chemotherapy. There's really no way around it, and that is because even if we had a successful surgery, there are microscopic cells that are still around that need to be killed. And chemotherapy does a really great job. It kills all fast-growing cells, and tumor and cancer cells are fast-growing cells. The drugs are administered typically into the bloodstream, and the chemotherapy is either given before surgery as part of neoadjuvant chemotherapy, as I had alluded to earlier, or it's given after surgery as part of what we call adjuvant chemotherapy. Sometimes women are unable to undergo surgery due to either the health conditions that preclude them from having a big surgery, and in which case then they would have chemotherapy. Now, the most common drugs that we use in the first-line setting for primary peritoneal cancer are carboplatin and paclitaxel, and sometimes we add bevacizumab, which is an antibody drug. And so these are really the most common drugs we use for chemotherapy and for primary peritoneal cancer and ovarian cancer, and are very effective. Radiation is very rarely used for primary peritoneal cancer and ovarian cancer. It typically is used for really more isolated disease, such as, let's say, nodal disease near the periodic nodes that are infiltrated with tumor, or potentially isolated liver tumors, which may respond with liver ablation. But typically radiation is not a common mainstay of treatment in ovarian or primary peritoneal cancer. I alluded a little bit to ascites. Ascites is fluid that occurs inside the abdomen. Many ovarian and primary peritoneal cancer patients present with ascites. It's fluid inside the belly that makes you quite bloated. And this oftentimes gets drained. We call that a paracentesis, and some women will need multiple paracentesis before they can get chemo or surgery. But usually with the combination of chemotherapy and surgery, this ascites fluid dries up, and the chemotherapy is able to effectively take care of it. Fluid can also build up in the chest. So pleural effusions, as you can see on this chest x-ray, can cause a partial whiteout of the chest x-ray. And that can also be managed by removing that fluid from the lungs, the lung fields. And you can do that with a procedure called thoracentesis, where a needle is being introduced in between the ribs, in the back, under ultrasound guidance, in order to drain the fluid that's within the chest, and then hopefully relieve the kind of shortness of breath, the breathing problems that a patient might have. So there's a lot of research that has really come to the forefront for ovarian cancer, and in that sense also primary peritoneal cancer, because those two are treated the same way. And I won't go over all of that. Many advances have occurred, from PARP inhibitors for BRCA mutations and HRD, to now folate receptor antibody drug conjugates, which all have really changed the lives of ovarian and primary peritoneal cancer patients. But my goal for this presentation was really to focus on peritoneal therapies. We know that primary peritoneal cancers occur primarily in the peritoneum, inside the abdomen, and therefore we're primarily looking for novel intraperitoneal or regional therapies. And there's one society in particular called the ISSPP, or the International Society for the Study of Pleura and Peritoneum, which focuses on diseases and cancers of the peritoneum and the pleura, which is pleura is referring to diseases in the chest rather than in the abdomen. And this is a society that really promotes these kinds of intraperitoneal or regional therapies. So I'll go over briefly what the latest research is for peritoneal cancers. So first, let's talk about regional or intraperitoneal chemotherapy first. And really, this leverages the fact that the peritoneal cavity, or this abdominal cavity that I explained earlier today, is really the principal site of disease in ovarian and primary peritoneal cancer. So meaning most of the disease that we see in primary peritoneal cancer is within the abdomen, either on the intestines or on the inner lining of the abdomen. So why not give chemotherapy directly inside the abdomen to touch those cancer nodules? And so in ovarian cancer and primary peritoneal cancer, this has been done by placing a port, and you can see the port here, with a catheter that leads directly into the abdomen in order to deliver the chemotherapy directly into this abdomen. And this allows for more concentrated chemotherapy to be delivered, and as well as for this chemotherapy to come into close contact with those tumor cells. And so this particular therapy sorry about that, that already jumped ahead. This particular therapy has been demonstrated to have an overall survival benefit in ovarian cancer and primary peritoneal cancer. However, the side effects, unfortunately, really preclude a general uptake of this therapy in most communities in the US and the world. And so this has really gotten out of favor, and we don't routinely do intraperitoneal chemotherapy, also because there's other therapies now available. Now, one regional therapy, intraperitoneal chemotherapy, which has become much more popular and is part of our routine armamentarium nowadays, is heated chemotherapy, or HIPEC. Hyperthermic intraperitoneal chemotherapy is a treatment that we deliver at the time of surgical debulking. In fact, actually interval surgical debulking for ovarian or primary peritoneal cancer. It requires a debulking surgery, meaning we have to clear all of the tumor that I had explained earlier in the big debulking surgery. And then we can place temporary catheters during surgery and give the heated chemotherapy through a pump as you can see here, and then cycle it through the abdominal cavity in order to have the heated chemotherapy come in close contact to the tumors that may still be, the microscopic tumors that may still be remaining after the surgery. And the rationale for the heat is that it helps the chemotherapy work better, because the chemotherapy actually can be a little bit more effective at slightly elevated temperatures, such as 42 degrees of Celsius. And we also know from a randomized clinical trial in ovarian cancer that HIPEC adds to the overall survival of ovarian cancer patients by about a year when given a time of the interval debulking. So we have a good rationale and we have clinical evidence that HIPEC works in ovarian cancer. Now, intraperitoneal chemotherapy has really undergone an evolution over the last several decades. We've gone from IP chemo to now HIPEC. And now the question is, could we improve on this? And what is the evolution? What is the next generation intraperitoneal chemotherapy? And so HIPEC is a novel therapy that can be given also directly inside the belly. But this is given for patients in the recurrent setting, not in the first-line setting, and it doesn't require surgery, meaning it doesn't require a surgical debulking to remove all of the tumor. So the HIPEC is essentially chemotherapy that is given inside the abdomen as a spray through a device, which is a aerosolizer or nebulizer. We do this at the time of a small surgery, a minor surgery, where you only place 2 or 3 little ports, tiny little incisions, like keyhole incisions. And these kinds of surgeries are pretty routine. Most patients will understand these maybe as laparoscopic surgery or surgery for, let's say, removing a gallbladder or removing an appendix. Usually that's what laparoscopic surgery is used for, except that during our kind of laparoscopic surgery, we don't do any removal. We don't actually do any debulking surgery. It's really only used, I apologize, it's really only used for delivering the chemotherapy, this aerosolized spray of chemotherapy. And the thought process of doing this as a spray is that the rationale is that the chemotherapy will disperse more evenly throughout the abdomen and to be able to reach every single little corner inside the belly, and therefore reach all of the tumors. But also go deeper inside the tumor in terms of depth of tumor reach, because the pressure that we at the same time give inside the abdomen, which is routinely given for these kinds of surgeries, can also drive the pressure, drive the chemotherapy, the drug deeper into the tissues and the tumors. So currently HIPEC is used in an experimental setting in the US. In the US, we have a clinical trial here at City of Hope. We use it for recurrent ovarian cancer. So, and as well as a number of GI cancers, such as colorectal and stomach cancer, for whom surgery, meaning debulking surgery, is not an option. It's been demonstrated to be very safe. And we are essentially continuing further clinical trials to determine that it's efficacious in recurrent ovarian cancer. So I just want to briefly demystify HIPEC versus HIPEC. I see a lot of patients who come to me and use those terms interchangeably, and they're really very different. As I mentioned, HIPEC uses heat. It's actually curative. We use it at a time of surgical debulking, meaning a big debulking surgery to remove tumor. It's not repeatable. It's only a single dose. And there are some toxicities, such as kidney side effects. Whereas with HIPEC, we don't use heat. We use pressure. We use a nebulizer. It's considered currently a palliative therapy, meaning we use it to reduce symptoms from cancers. We don't perform a surgical debulking. We do repeat it. We repeat it at least 3 times, meaning you have the HIPEC and then you repeat it 4 to 6 weeks later, and you do that up to 3 times or more. And the toxicities are considered pretty low. We have enrolled a number of ovarian cancer patients in our HIPEC trial. This is actually my patient, Irina. She underwent 6 cycles of HIPEC and did really well. She had a great response. And she was featured in this Cure magazine, which is a patient-oriented magazine, where she described PIPEC as a really well-tolerated therapy. She thought that the side effects were really better than what she saw with the intravenous traditional chemotherapy that she had. And so she really was a fan of this therapy, and it really worked well for her. She had a good response with regression of her tumor. So as I mentioned, we do have a PIPEC trial at our institution. We're actually the only US PIPEC trial. I'm the national PI for this trial. My co-PI is Dr. Raouf for the GI side of the PIPEC trial. And we have numerous collaborators, including at the Mayo Clinic, as well as Northwell, where we have a number of really great collaborators who also enroll patients into this PIPEC trial. And we enroll patients with ovarian, uterine, colon cancer, appendiceal cancer, as well as gastric cancers. So the takeaway points from this lecture are that primary peritoneal cancer is rare. It's really treated in the same way as ovarian cancer. And the novel research from primary peritoneal cancer is really the same as for ovarian cancer, with a difference that we also focus on peritoneal therapies, such as PIPEC and other novel intraperitoneal therapies. So I hope that this was an interesting lecture for you, and I'm happy to answer any questions. Thank you.
Thank you, Dr. Dellinger, for your informative presentation. We really appreciate you joining us today.
Of course, my pleasure.